focus about a very important topic of renal tubular acidosis, which is very, very common and important from perspective of rickets and refractory rickets in that regard. So we'll discuss about pathophysiology of RTA, then we'll talk about the basic causes, and then we'll talk about evaluation and management. Since pathophysiology is very crucial, we'll go in more detail, and a lot of people have issues in terms of understanding the pathophysiology. So when we talk about the acid-base balance, we are mainly talking about the amount of protons which are available in a particular situation. How much proton is there in the body? If the protons are more or the bicarb is less, there will be acidosis. That is the basic situation. There are two major organs which regulate the whole process. One, of course, is the respiratory compensation. The other is the renal compensation. The respiratory process involves the carbonic anhydrase, in which converts it into water and carbon dioxide, which is then taken off by lungs. So all the acute changes which happen with regards to the acidosis and other parameters are happening mainly through the lung. That is, of course, important. But for chronic changes, we are mainly talking about the renal excretion of that part. Now, when we talk about the acid-base balance by the kidneys, there are two aspects. How much protons you are able to remove and how much bicarbonate you are able to retain. So essentially what we are seeing is that proton is actively transported while bicarbonate is very easily filtered. This is an important concept to remember. You need a lot of energy and you need a lot of specific transporters which can transport the proton, while for bicarbonate you don't need anything. It is just going to be filtered in a huge amount. So the loss of bicarb will be huge in that perspective, while proton, there will be a daily, it will be produced in that perspective. Now 99%, large amount of bicarbonate is actually reabsorbed. So that's very important. So problems can happen in either the pushing out of protons or inability to reabsorb bicarb. And this is the basic difference when we talk about distal and proximal RTA. So what do you think is the problem, Dr. Prateek, in distal and versus proximal?
In proximal RTA, there is loss of bicarb. The loss of bicarb. In distal RTA, the acidification is incomplete.
So one is a problem that you cannot excrete acid. The second is you cannot retain alkali. Which one will be more severe?
The loss, the absence of retaining of bicarb.
So if you cannot extract bicarb, it will be more severe or less severe?
It will be self-limiting if the bicarb.
Because once the bicarb becomes low, you won't filter it. So that will be a self-limiting disease. But if you keep on producing acid, that is going to be a difficult problem. So distal RTA in principle will be much more severe as compared to the proximal RTA, and that is something which we'll discuss subsequently in that regards. Now, as we discussed, the acute regulation is largely through the lungs. So as soon as your bicarbonate comes down or your proton goes up, your CNS centers become active, they start hyperventilating and CO2 is washed out. What is the normal correction of CO2 for a bicarb level? And this is what you need to understand, whether this is a compensated, uncompensated, overcompensated metabolic acidosis. So
it's 1.5
plus 8. So basically, if your bicarb is 10, you multiply by 1.5, it becomes 15 plus 8, that is 23. That should be the rough CO2, which is there. So when you are looking at a blood gas report, we'll discuss that in a different section altogether, because acidosis per se is a different thing altogether. But just to summarize here, when you're looking at the report, always look at what the CO2 is and what the bicarb is, and whether it's a primary problem in terms of bicarbonate deficiency, which is a metabolic acidosis, or a CO2 excess, which is a respiratory acidosis in that regards, and whether it is compensated or not. So for every single molecule of bicarbonate, multiply by 1.5 plus 8 should be the compensated CO2 in that regards, and that's what we need to understand in that setting. Now, there is also a role of GI secretion and excretion, but that's more in a pathological form, not in a physiological. So when you regulate bicarbonate, you don't change your intestinal absorption. But there may be conditions in which you may lose bicarbonate that may cause a problem of acidosis. There may also be conditions in which you will lose acid, and that is going to cause alkalosis. So which level of loss will cause metabolic acidosis and which level of loss will cause alkalosis? Like which lower and upper GI if you divide in that setting?
So in lower GI, the amount of bicarb is more.
Yeah.
Whereas upper GI, HCl is more. So
So when you have more vomiting, you expect hypokalemic alkalosis as a major phenomena, while if you have diarrhea, you expect a hyperchloremic metabolic acidosis, which is just like an increased anion gap situation, similar to what happens with RTA. So lower GI loss is more of a pathological cause of acidosis. It doesn't have much role in terms of routine pathophysiology. So you don't change your GI. So it's mainly the kidneys and the lungs, which are the major regulator in that perspective. So if you just summarize that, if there is acidosis, it can either be respiratory, in which your carbon dioxide is very high, or it may be metabolic. When we say metabolic, it means that your carbon dioxide is normal or low. It may be there if you have some other acid which is accumulated. It may be a lactic acid, it may be ketones, it may be organic acids, and this is what we call as high anion gap metabolic acidosis. So you may have accumulation of lactate, pyruvate, organic acids, or even ketones. The most common cause that we encounter is more of a ketoacidosis which happens. Then this is a high anion gap situation. The other problem could be that you are not able to excrete proton well, or you're losing too much bicarbonate. This is what is renal tubular acidosis, and this is what we call as hyperchloremic or a normal anion gap metabolic acidosis. This is something which we'll discuss subsequently in more detail. Now, very important thing to understand is how do kidneys regulate the excretion of these proton and bicarbonate. Now, as discussed, protons require an active push to be taken out. So there is a specific mechanism which requires energy, which requires transporters, which require the protons to go out in that perspective. So it's 1 millimole per kg of proton is produced every day, and it is excreted mainly at the level of distal tubule in that perspective. Now, bicarbonate is basically filtered freely. So bicarbonate can go out in the kidneys very quickly. So you have huge amount of bicarbonate which is filtered, but most of it is reabsorbed. 99% of bicarbonate is reabsorbed. So even if your fractional excretion of bicarbonate, so that what it tells us is that Fe bicarb is around 1% in usual situations. So when we talk about fractional excretion of bicarbonate, when we compare proximal versus distal, we say less than 5% is distal, more than 10% is proximal RTA. So if you're losing more bicarbonate, of course, you will have an issue which will happen in that perspective. Now, 90% of bicarbonate absorption happens in the proximal tubule. So problems in acid excretion are largely distal. Problems in bicarbonate excretion are mainly proximal. This is what it basically tells you. So let's go one by one. So as I said, lot amount of 70 millimoles per kg per day. So this is a huge potential to cause acidosis. So theoretically, you may think that proximal RTA may cause much severe acidosis, but we'll discuss why it is self-limiting. So out of this 70 millimoles per kg per day, or around 4,000 millimoles in a day, 90%, as I said, is reabsorbed at the level of the proximal tubule, mainly through the carbonic anhydrase, which basically converts it into HCO3, and sodium bicarbonate transporter. 90% of it is absorbed here. The small amount of it is remaining. Now, when you have this proximal tubule, it is also absorbing other things. It is also absorbing phosphorus, it is also absorbing amino acids, it's also absorbing the glucose. So if there is a proximal tubular dysfunction, you will have amino acid urea, you will have glucose urea, you will have phosphate urea. And because of phosphate urea, you will have rickets. So bony deformities would be much more likely in proximal RTA at an early stage, because your phosphorus will be lost hugely in that setting. You will also have what is known as Fanconi syndrome if you have a combined proximal tubular dysfunction. Now, out of the remaining bicarb, a bit of it is absorbed at the level of distal tubule, around 10%. So it's mainly the proximal dysfunction which causes a problem in terms of bicarbonate loss in that regard. Now, as discussed, proton has to be actually pumped out. It's not very easy to really, when we talk about gastric acid production, we know there is a proton pump. You can't easily exchange proton out of a particular cell. So there is a specific proton transporter, which basically uses proton potassium ATPase and proton ATPase to push this potassium into the lumen. So there is a huge gradient. So this results in a 250 times more acidification of the tubules as compared to the cell. So there is a big push there, which means if you have any problem which is there in these channels, you will have a difficulty in pushing proton out. and that's going to be a big problem in that regards. If you compare this to bicarbonate, bicarbonate was 70 millimoles per kg. This is only 1 millimoles per kg, but every day if you produce that much, it will be a huge problem which will accumulate. Now this proton has a tendency of going back, because what happens, you can go in and go back, but very difficult to push it back. So to push that part again back in the distal tubule, there is a specific mechanism which is done via the renal ammonia production. So if you have metabolic acidosis, the kidneys produce ammonia, which forms NH4 plus or ammonium along with proton and take it out. So very importantly, it is a two-step process. The first step is to push it in the lumen using proton ATPase and proton potassium ATPase. The second step is combined with ammonia to NH4 plus, and then you ask them to take it out from the body, and that's how it works in that perspective. Again, whatever is produced is basically removed. So this is the homeostasis which happens. Now, very closely linked to bicarbonate and proton is the potassium excretion. That's important because a lot of these disorders have a potassium issue also in that regard. Now, we know that it is filtered freely, and a large amount of potassium is actually absorbed at the level of the proximal convoluted tubule, but a significant chunk is also excreted at the level of the collecting duct. And this is closely linked to the epithelial sodium chloride channel. Now, this EANC channel allows sodium to be resorbed along with chloride. The chloride goes slowly while sodium goes fast. So what will happen with this?
So there is an electropositive charge inside the cell.
So inside the lumen, you will have electronegative. So it will be negative, and therefore all the positive ions that you have potassium, you have got proton, you've got magnesium, you've got calcium. They will then try to go outside to compensate for that. So this electronegativity in the tubular lumen will cause potassium to come out, proton to come out, and magnesium, calcium to come out. So if you have metabolic acidosis, in that setting, you will expect potassium to be lost in that regards. You will be losing calcium, so you will have hypercalciuria, which will also happen in that setting. So hypercalciuria is not unique to distal RTA. It also happens with proximal and other functions as well in that regards. Now, ammonia will, of course, take this proton out, as we have discussed earlier in that setting. If you have hyperkalemia, what do you think potassium will like to do in terms of proton excretion?
So it will take in hydrogen, proton, and put out potassium.
So if your potassium is high, this potassium is now competing with proton to go out. So body has got a choice, either it allows this potassium to go out or the proton to go out. So if you have hyperkalemia, the preference of the body is to prevent hyperkalemia. It is not bothered about mild acidosis. So in situations of any cause of hyperkalemia, there will be an increased potassium loss, which will cause lesser loss of proton. There will be acidosis. So we said that acidosis causes hyperkalemia, but hyperkalemia will also cause mild acidosis, and this is what is known as type 4 RTA. So this is important. So that's why how it does it, it inhibits ammonium production. If your potassium goes up, the ammonium production comes down, and therefore you will excrete more of potassium rather than proton, and this is how the whole thing is compensated in that perspective. Now, if you have excessive sodium load, Manoj, what will happen?
As we discussed, in extreme amount of excessive sodium load, the potassium will lose as well as other.
So if your sodium becomes more, the amount of sodium which reaches the distal tubule or the collecting duct is more. The body feels that, okay, we are losing sodium. Sodium is more important for the body because of the volume and all those status. It will try to extract that sodium. And when you extract that sodium, you will actually be losing potassium. So any condition which causes sodium load will cause loss of potassium. This is relevant when you treat proximal RTA. Proximal RTA typically does not cause hypokalemia at diagnosis, but when you give bicarbonate, your sodium delivery to the distal tubule increases, which causes greater loss of potassium, and that's why hypokalemia worsens. So during treatment of proximal RTA, the hypokalemia worsens, while in distal RTA it improves. We'll discuss as to why that happens later on, but this is important to remember. Any condition which increases the sodium load will basically cause potassium to come out of the cell, and that's important to there. And of course, if your RAS axis is hyperactive, it will also cause potassium to lose. That's why hyperaldosteronism causes hypokalemic alkalosis, as we've discussed earlier also in that regard. Now, what should the body do if somebody has acidosis, Dr. Pratik? What do you think should be done? The first thing.
So if there is acidosis, the pH of bicarb should come down.
So your urine should become acidic. So if you have acidic blood, the urine should be acidic. If you have concentrated blood, your urine should be concentrated. And that's why we say if you have a concentrated blood, but a dilute urine, that is DI. Same here, if you have a acidic blood, urine should be acidic. If the urine is alkaline, it means that there is a problem in acidification, which is distal RTA. Normally, it is more like a proximal RTA. So first thing will be the bicarb excretion should come down, as you said. So this will cause pH to really go down in that setting. Ammonium production should increase because you want proton to go out. So ammonium will go out. That will cause increase NH4+. And to know that, you need to know that ammonium is actually an unmeasured positive ion. So when you measure the urinary anion gap, if your ammonium level goes up, your urinary anion gap will become negative. So in conditions like gastrointestinal loss, when your ammonium production is intact, you will find that ammonium production goes up and you will have a negative urinary anion gap. While in conditions like RTA, where actually the problem is in terms of ammonium production itself, your ammonium will not go up and you will have a positive urinary anion gap. So urinary anion gap is the best marker to distinguish a gastrointestinal from a renal tubular etiology, and this is what we'll discuss subsequently from that perspective. So you'll have the acidic urine and potassium will be lost, because if you have acidosis, you will be losing potassium in that perspective. So now we've discussed a lot about pathophysiology, a few words about the etiology of RTA. Now, as discussed, there are two basic problems. Either you're losing more bicarb or you're not able to excrete the proton. That's the two basic mechanism. The third is if you have hyperkalemia, that will also cause a proton loss, which is going to happen in that perspective. So proximal RTA is in the proximal section. You will have main problem would be in the setting of bicarbonate loss. You're losing a lot of bicarbonate. Once your bicarbonate becomes below 15, the filtration cannot happen. You can't filter it, so how much more you will lose? So it's a self-limiting condition which is there. The urine is acidic. This is a normal, there is no problem in terms of acid excretion. Blood is acidic, urine is acidic. So urine pH is less than 5.5 or more precise less than 5.3, which is the cutoff we use. And there is no calcification. Why do these patients not have calcification?
Because of the citrate also loss.
So they do have hypercalciuria. It is not that they don't have hypercalciuria, but they are also losing citrate, which really prevents the calcification from happening. So hypercalciuria is not a distinguishing feature between proximal and tubular and distal RTA. Nephrocalcinosis does not happen in proximal because of the citrate urea, which is present in that perspective. Now in distal RTA, the problem is that you are either not able to pump the proton inside or that proton leaks out. So basically you're not able to excrete the proton in that perspective. It is severe because there is no self-limiting. It is keep on going to accumulate. Every day you will have 1 millimole extra. You're not able to take it off. So it will be more severe. You will never have acidic urine because you cannot excrete protons. So it's acidic blood with alkaline urine. That makes it very, very clear. And you will of course have nephrocalcinosis because there is no citrate urea. And because acidosis is more, the severity of hypercalciuria will also be more. This is something which is expected from that perspective. Type 4 RTA is a problem of either this channel or the renin-angiotensin-aldosterone system. It typically causes hyperkalemia. All other forms of acidosis, as we discussed, RTA will cause potassium loss. Type 4 RTA will cause high potassium. So high potassium with acidosis with renal, think of a renin-angiotensin-aldosterone defect.